Respected chairpersons, moderators, good evening and best wishes to all delegates of India Live. I am also thankful to course directors of India Live, Dr. Seth, Dr. Samuel Matthew and all others. Really we are very, very happy to associate with India Live. Today we will show very complex PCA, calcified LM bifurcation. Let me discuss about today's case. A 75-year-old male, known hypertensive and diabetic, presented with unstable angina of 1 week duration. He underwent troponin I test for angina, showed 600 nanograms, which was done outside in some other hospital because of the classical angina, markedly elevated troponin I. His creatinine is normal, other tests are no significant abnormality. You can see the angiogram. Right coronary, there is a distal very, very tight critical lesion, 99% lesion, and the right coronary is just with the tortuosity. This is the L6. There is a very tight lesion with the tortuosity of the left circumflex. You can see the almost 90% lesion in acute bend. Then LAD appears to be intermediate lesion, and there is a significant calcium of the proximal LAD. Distal left main, distally tapered. Diagonalis appears to be fine. So type 3 vessel. With this angiogram, what we thought, because patient is having a classical unstable angina, culprit vessel is right coronary. Then we did the right coronary stenting, and that is using, initially we dilated with 2 mm balloon, and we used 2.5 to 18 Zines. Because of the tortuosity, use the guide plus 2, get into the distal right coronary, then it was implanted with a good TIMI grade 3 flow. This is the final angiogram view, right coronary, excellent result, good expansion of the stent, TIMI grade 3 flow. Then what we thought, because the LAD is associated with a calcific long segment lesion, intermediate lesion, our intention to check whether that is significant or not before doing the L6 stent. So before doing L6 stent, we did FFR study with NTG as well as adenosine. It showed 0.8 to 0.81. That means it's a borderline, almost 0.8, but maximum time it was showing 0.81. Any side branch stenosis can influence the main branch FFR. Here, because the tight left circumflex, that is more than 90% lesion, I felt that definitely it may have some impact on the LAD FFR. Our intention was to do the LAD FFR after completing the left circumflex, because the side branch critical lesion can influence almost 0.2 to 3 points of the FFR. Again L6, there is a lot of tortuosity and thick fibrotic lesion. Then we did guide plus placed into the L6 ostium. Then multiple dilatation, 2.75 into 22 mm onyx was implanted. Here ostium relatively appears to be fine. There is no significant disease of the left circumflex. Our intention is to avoid the 2 stent technique, because compared to provisional stenting, the 2 stent technique associated with the increased MACE rate. So that is the reason we spared the left circumflex, because it appears to be fine. So we covered only left circumflex critical lesion. So after that we did the FFR study. You see the FFR study with adenosine after LCX stenting, which was 0.81, it became 0.75. That means significantly positive. We did the LCX and RC about 3 days back. Today we are planning to do the LM2 LAD assessment with OCT. Simultaneously we will acquire the OCT of the LCX, and our intention is, if the calcium is significant, thickness is more than 0.5, if the length is more than 5 mm, if arc is more than 270 degrees, we will go ahead with the orbital atherectomy, and followed by plaque modification assessment with the OCT again for any evidence of fractures on cuts are there, and any gain in the mean luminal area, and subsequently image guided stent implantation and optimization of the stent implantation. Now we acquired the OCT prior to the PCA procedure. So let me show the analysis of the OCT. We have used the OpStar, the new version of the catheter, which is much more trackable, and even in tortuous vessels, definitely reusability is more, Now you can see here also some fibrous is there. Luminal area here 3.92. There is a significant plaque. See here very tight from here onwards. That is a diagonal branch. There the luminal areas are very good, 7.8, 5.6. Now you can see the calcium, but that is less than 180 degree. Only 90 degrees I could see the calcium. Area is only 5 square mm. Now here onwards you see. See there is a calcium almost 180 degrees, but more of deep. See left main area 8.46 distally, 9.3. See proximally the left main is almost 13.5 square mm. Now LED ostium 2.47. That is a significantly stenosed disease and almost nearly 180 degrees of calcium. This is also deep calcium, deep and almost nearly 120 degrees deep calcium. You can see here there is a significant calcium, 6 o'clock and 3 o'clock position. There is a significant thick calcium nearly 270 degrees. This proximal LED significantly calcified. Further you can see here almost more than 270 degree calcium, thick calcium, more than 1 mm thickness. Here fibrosis, more of fibrotic plaque. So here area 5.5. Where to land? So there also another plaque is there, but this is the good landing zone. 4.35. We'll land it here. Thick fibrotic plaque 3.7. Here area is good. Yeah, there is thick calcium. So we'll take 48 mm. We'll do the plaque modification using the orbital atherectomy. But if you take 48 mm, you are not going to cover the LMCA. What we are doing, already we have acquired the imaging. So image showed there is significant calcium of the proximal LED. Mainly the thickness is more than 1 mm and length is more than 5 mm. Arc is in some areas is almost 270 to 300 degrees. So the calcium expansion index is very high. As per the imaging criteria, definitely patient requires some plaque modification. So what kind of plaque modification here, whether to go with rota or whether to go with orbital atherectomy. So our intention unstable angina, recently LCX and RCA was done, and large vessel, so almost like a distal LM 4.5 mm and proximal LED also almost 3.5 mm vessel. So large vessel and more deep calcium. So ablation of the deep calcium and a larger vessel, definitely orbital has a superior role compared to the rota. Rota mainly for uncrossable lesions, definitely very severe critical lesions has a bigger role. But here what we thought, because the slow flow, no flow is less with the orbital atherectomy, because whatever particles generated during orbital atherectomy is only 2 microns versus 7 to 10 microns with the rota ablation, and it has advantage of forward cutting and backward cutting. So the overall ablation time is shorter because you are ablating while doing forward motion and backward motion, and at the same time the ablation catheter moves around the periphery in the vessel lumen, so it can cut even any calcium nodule is there, any eccentric calcium is there, it can ablate the deep calcium very nicely, and for larger lumen it is more effective, and that's the reason we have chosen. We have only one bar, that is 1.25 bar, can use the 80,000 or 1,20,000. So standard guidelines, better to use only 80,000 revolutions per minute, and slow movement of the bar, that is 1 mm per second, very slow movement. That's the reason the complication rate is low with a 80,000 and with a slow movement and during forward and backward motion, because the forward flow is also maintained, slow flow is less. Whereas in rota, while doing rota ablation, there will not be any forward flow, but because this orbital moves around the vessel circumference, there is a space in the central portion, so that there is a forward flow. So because the forward flow is there, debris will be cleared on fast track basis. So one is particle generator is smaller and the forward flow is maintained, moves around, bigger arc of ablation, and it can cut that even deep calcium as well, calcium nodule, eccentric nodule, and you can do it backward and forward motion. So orbital can be used for left main ostium. You can introduce, you can during reverse movement you can do the backward cutting, or you can also do the forward and backward cutting if a good alignment is there. There is a significant calcium which requires modification. Then what we are doing, we are exchanging Viper wire using the microcatheter. So this is the Viper wire, 1 mm per second. That it has to be 80,000. Slowly 1 mm only you have to move forward and backward movement. If you do 1 mm, then what happens? It produces more ablation. The ablation almost equal. You can see the elliptical shaped. See, before you start orbital, always you should see this fluid should come out of this hole. Say then that 80,000, 1,20,000, apply the advanced knob and move it and see is it moving freely or not. Then similarly 1,20,000 will activate 120. Now we have tested the orbital atherectomy. Once it enters into the catheter, that time activate the glide mode. Yeah, now you can activate the glide mode. So when you press it for longer time, automatically it blinks. So that indicates glide mode. So when you are pushing forward, the brake should be deactivated. Now I am moving forward. Now it's moving very freely without any resistance. That's the advantage of glide mode. If you want slightly, you can pull the wire. So when you start the orbital atherectomy, the brake should be activated and press the knob, and the advanced knob should be pressed, and then do the forward and backward cutting. And the speed should be very, very slow. Just 1 mm per second. And that time give enough ablation, then gradually move backward. Very slow movement is very, very important. High speed ablation capacity is less, complications are more. I am starting with 80,000. Now I am going very, very slowly. I am doing forward cutting 1 mm. Now you see slow movement only. You should go very well. So for every 20-second cycle, there will be a beep. So once you get the beep, immediately you stop, and again 15 to 20 seconds interval should be given. Then you can redo the next cycle. The reverse cutting also should be with a slow speed, that 1 mm, 1 mm, 1 mm, 1 mm. Now I am going with a reverse cutting. Now you can observe very slowly we are moving. Now again, because of beep, then I stopped. Again we are giving some more interval. Now I am doing backward and forward cutting. Mainly the proximal segment is significantly calcified. So standard guidelines recommends use only 80,000 revolutions. Don't use 1,20,000 only unless it is very, very large vessel. But especially if the vessel diameter is small, don't go with 1,20,000 because complication rate is very, very high. But if you maintain the slow withdrawal, slow backward and forward movement, you can get the same area of ablation which is equivalent to 1,20,000. So that's the reason move 80,000 slowly 1 mm by 1 mm, and that if you maintain, complication rate is low, and at the same time the ablation capacity of the bar will be more. So beauty of this device, you can use it for the vessel size between 2.5 and 4 mm. So even left main also it can ablate very nicely. Left main almost 4 to 4.5 mm is there in majority of the patients. Left main with severe calcium also, the ablation capacity of this device is much more compared to rotablation. Particularly the left main bifurcation lesions with calcific nodules. Suppose LAD osteum is calcified, L6 osteum is calcified, where you are unable to track with a balloon, very difficult. In that case also you can do the reverse cutting also. If needed, you can take the guide liner, with guide liner push place with a glide mode. Support you can place deeply, and you can pull back and do the reverse cutting. Particularly in very highly tortuous lesions, forward cutting should be avoided. If at all, if you want to do it, you can place distally. If there is no problem in placing the orbital, after that you can pull back and do the reverse cutting. Even you can do it for left main osteum, right coronary osteum. Even some reports, almost 40 case series is there, where they have done it for even under expanded stents also. It is bench tests have shown it can be used for under expanded stents. It can effectively modify the calcium behind the stent struts. You can remove the stent struts. You can also debulk the calcium behind the stent. That is also another advantage. Now here go with 1,20,000. Definitely, because the area is bigger, bar movement will maintain 1 mm, so that you can get the bigger area of ablation. Orbital atherectomy, then we'll proceed. Otherwise we can go down until that area. And then we'll go to 80,000 because distally vessel is small. Don't go with now you can see the ST elevation also on ECG. We'll pull the burr into the catheter. We'll give some gap. We'll allow it to recover. If needed, you can give a small dose of dilgium. You can give adenosine, nicorandil. Even SNP, sodium nitroprusside, also very useful. So whenever there is slow flow is there, you can give intracoronary atreline, you can give sonide, you can give verapamil, diltiazem. All these drugs are very useful to control the slow flow. And at the same time, if the pressure is low, just to try to improve the pressures by adding inotropic support and fluids. When the pressure is better, then slow flow will subside. And in between, give some gap. And when the slow flow is there, is it only because of the really classic slow flow? Classic flow slow means less than TIMI grade 3 in the absence of dissection, in the absence of coronary obstruction or spasm. So, whereas you have to rule out other cause of slow flow. Any dissection is there, tackle the dissection. Now see, still the flow is less. Good. Now flow is improved. So this is very important. Improve the flow, then you proceed. Distally, don't use the 120, only 80,000, 1 mm per second. You can see mild ST elevation. We'll try to give a small dose of NTG. Now you can see the ECG, ST significantly changes regress. Now we acquired the OCT prior to the PCA procedure. So let me show the analysis of the OCT. You can see the fractures here, nice fracture where there is a thick calcium is there. Here also you can see the fracture in the calcium. You can see the multiple fractures and adequate ablation. There is a gain in the main lumen area where exactly the calcific segment is there. Because after orbital atherectomy, our intention is to see how the calcium modification. So whenever you use imaging, use it optimally. What for you are doing? Once you do the plaque modification, is it adequately modified or not? So once you do the OCT imaging, if there is any evidence of calcium fractures or cuts or mean luminal gain, definitely indicates adequate plaque modification. Whatever stent you are going to implant it, it's going to expand it very nicely. So for that, with that intention, we repeated the OCT after plaque modification, which showed definite fractures, gain in the mean luminal area. In spite of plaque modification, we are facing difficulty in placing the proximal stent. So we'll try to, maybe because of the bias, the previous starts might be disturbing this one. I think covered. Go ahead. Implant, deflate. Good, flowing well. After stenting the left main to LED stent, we did the pot balloon using the 4.5 into 8 mm balloon, and the from carina to the ostium, including ostial flaring, was done. After that, again a 3.5 mm balloon was taken, and the LED was further dilated because the calcified vessel, some under expansion may be there. So adequate expansion post procedure is a must in calcified lesions. So you can see the 3.5 mm balloon into 15 mm NC balloon. We further dilated the entire LED segment, and the proximal portion of the LED we used 12 to 14 atmosphere. Distally we used 8 atmosphere, and after that then we acquired the OCT image. So again OCT image showed nicely expanded stent, including the left main area. We got almost 13 square mm. LED ostium before procedure, it was almost 2.4 square mm. That means very, very tight lesion. And post stent LED ostial area we got 9 square mm. It's a very good area, and everywhere the entire stent area showed more than 5 square mm. Though OCT showed the 80% expansion, 81% expansion in some areas, which is also acceptable. Suppose if less than 70%, that is under expansion. But here mean stent area, if you see, more than 5.5. You see L6 ostium also nicely patent. You see the L6 ostium also nicely opened very well. No struts across. So we achieved more than 80% area with very good stent areas, and very nicely opposed stent well expanded stent and without any medial edge dissection. That distal landing zone, the plaque burden is less than 50%, and there is no lipid rich plaque. That is very important to see that future in the suppose when you follow up these patients, suppose if you are having a lipid rich plaque, you are landing in a lipid rich plaque, or if the patient is having a edge dissection, or if malapportion underapportion is there, the MACE rate is very high. In this case, we assess the morphology. The morphology showed the calcium, and the calcium imaging suggested us to do the plaque modification. We used the orbital and further further plaque modification with the Wolverine and NC balloon, and subsequently stent was implanted. Once stent is implanted, we have before stent we have seen the evidence of adequate plaque modification in the form of fractures, and once stent is implanted, we met with MLD max, that is there is no malapportion, opposed well, and there is no medial ejection. So we have fulfilled the entire criteria. This case triple vessel disease where LCX was done, RCA was done, LAD to LM stent was done, but purposefully LCX ostium was spared with a very good luminal area, and bifurcation mode showed the excellent LAD ostium and LCX ostium, and without any strut sacra the LCX ostium. Let me thank from Kim Sunshine once again. Let me introduce our team members, Dr. Shailendra Singh and Dr. Vijay Kumar Reddy, my associate Dr. Pranay, cardiology associates Dr. Rajaram, Dr. Prashant, head technician Vasu, and senior head sister Nirmala, Prem, and all my wonderful team. With their help, I am able to do this type of cases. Thank you one and all. I wish you all the best and enjoy India Live. Thank you one and all.